Rajesh sir, I request you to start the session, sir. I'm getting the other faculty as soon as possible, sir.
Right.
Arvind, please start sharing the screen. It is 8 o'clock. Swaminathan sir, good evening, sir. Sir, am I audible to you, sir? Rajiv, please introduce yourself, your unit chief, head of the department, and start your presentation. Dr. Rajiv Sahai sir will conduct the classes today.
Yes, sir.
Thank you very much. Please
Yes,
switch
sir.
on your video. Yes, you're good to go, Dr. Rajiv.
Good evening, everyone. I am Dr. Rajiv, second year postgraduate, pursuing in Madurai Medical College. My chief is Professor Dr. K. Saravanan sir, Professor and HOD of Department of General Surgery, Madurai Medical College.
Yeah, go on.
Good evening. A
Yeah,
44-year-old A 44-year-old female resident of Paravai, a daily wage worker by occupation, presented to the OPD with chief complaints of lump in her left breast for past 3 months. History of presenting illness. The patient was apparently asymptomatic 3 months back, after which she noticed a lump in her left breast, incidentally while taking bath. It had an insidious onset and gradually increased in size to attain current size. The lump was initially the size of a coin, and now it has progressed to attain the size of a ball. The lump is associated with dull aching pain for 2 days following core needle biopsy. The pain was intermittent in nature and dull aching type with no radiation and relieved on medication. No history of nipple discharge, no history of recent nipple retraction, no history of trauma to left breast, no history of loss of weight or loss of appetite, no history of bony pain, no history of cough, chest pain or breathlessness, no history of abdominal pain or abdominal distension, no history of jaundice. Past history, no history of similar illness in the past, no known comorbidities like diabetes or hypertension, no history of any previous surgeries, no history of radiation in the past to chest wall, no history of any intake of OCTs. Personal history, he consumes mixed diet, no history of alcohol consumption, not a smoker, normal bowel and bladder habits, normal sleep pattern. Menstrual history, she attained her menarche at the age of 15 years, regular cycles with normal flow. Her last menstrual period was 10-10-2025. Marital history, married at the age of 21 years of age, non-consanguineous marriage. She is nulliparous and has no history of breastfeeding. Family history, no history of breast cancer in first or second degree relatives, no history of ovarian, prostate, colorectal, or pancreatic cancer in the family. Summary, a 44-year-old male presented to the OPD with a lump in the left breast for past 3 months and history of pain over the lump for past 2 days. No relevant family history or any comorbidities.
Okay. Rajiv, let's go back
Yes.
to your first slide. So what do you think by history you're taking? Just 3 months history. Uh,
Yes.
size of a coin and softball. You must be knowing what's the size of a coin. What's the approximate size?
1 x 1 centimeter, sir.
1 centimeter. Okay, 1 centimeter is just about palpable,
Yes.
right? Okay, and what's the size of a softball?
Softball around 5 to 6 centimeters, sir. 5.
So you mentioned that, no? You mentioned why,
Oh,
why, 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 why do all this here? Just
okay.
say 1 centimeter or 2 centimeters and 5 centimeters now.
Okay, sir.
Okay. And next slide. There's dull aching pain after a core biopsy.
Yes.
So any skin changes after core biopsy?
No, sir. No skin changes noted,
So
sir.
you have to mention that, right? It could be that because of core biopsy there could be infection or just pain because of that. So you got to
Oh,
mention that there's no infection. So all
okay.
the signs of inflammation should be mentioned here, that there's just pain, but no probably skin changes or anything else.
Okay, sir.
Intermittent in nature radiation. Okay, no nipple discharge. Okay, trauma to left breast. What kind of trauma are you looking for?
Even a minimal trauma can cause traumatic breast fat necrosis, sir, and can mimic like
No. Hang
a
on.
lump
What
in
is
it.
chronic fat necrosis?
Traumatic fat necrosis is trauma to the breast, sir.
Just any trauma. So if you just give her a punch, she can develop traumatic fat necrosis.
Destruction of the fat lobules.
No, this usually is seen in chronic trauma. This is seen in elderly women who have floppy breasts, and when they sleep on the side, the elbow presses onto the breast, and that causes chronic trauma, and that leads to chronic fat necrosis. Okay, this is
Okay.
just not any trauma.
Okay.
Okay, next slide. So, how will you differentiate chronic fat necrosis from malignancy of the breast?
The size is usually constant in case of a fat
Right, it will not
necrosis.
change. It will not change. Right. Also,
A recent retraction of nipple discharge can be seen in cases of uh, carcinoma.
there will be no signs of local or distant spread.
Yes,
It's a benign condition, isn't it? So that what is malignancy? Either local spread or there's change in size and there is spread.
yes,
These are the two characteristics of malignancy,
yes, sir.
right? So these two will be absent there. Now you don't have to give us a whole list. You've not given us CNS findings here. You just say that, look, if you start listing out all the features of secondaries, you're bound to miss something. You just say no history suggestive of distant metastasis.
Okay, sir.
And then if someone asks you what are the signs or symptoms of distant metastasis to the brain or to the lung, then you list it out. Okay?
Okay, sir.
Because you've not told me brain mets. Have you
Headache,
taken history?
vomiting, and yes, sir. No history of headache or vomiting and
You've
seizures,
not
sir.
written it here. So that's what I'm trying to point out.
Yes, sir.
Don't do this. Next slide. Uh, Past history. Previous surgery. What kind of surgery are you looking for? Suppose she's undergone an appendectomy. Will that be a risk factor for CA
No.
breast?
She might have undertook surgery for a carcinoma in a different place, like a colorectal carcinoma or prostate cancer, or
No, prostate
the
cancer is not for her, please.
sorry, colorectal
Surgery,
cancer or ovarian cancer,
a risk factor could be any surgery in the breast before.
or the opposite breast or on the same breast.
Yeah, any surgery on the same breast is a risk factor for future malignancy.
Yes.
Okay, next slide. Mixed diet, alcohol, smoking, bowel, sleep pattern normal. Okay, next slide. So is this early menarche, late menarche?
Early is usually less than 12 years, sir, and late is greater than 18 years.
So this almost normal. Okay,
Yes.
and she's premenopausal, right?
Perimenopause, yes, sir.
Now, what are the risk factors in this patient for malignancy?
She's nulliparous with no history of breastfeeding, sir. Uh,
First of all, she's a female, a
Female,
lady,
age of 44,
age, right? What else?
a slow growing lump, and she's nulliparous with no history of breastfeeding.
Right. So these are. So had she taken any history for infertility?
No, sir, they are not evaluated for infertility, sir.
So you should mention here why. Why is it important?
They could have taken pills, OC
She could have
pills,
taken hormones. Yeah, it's hormones for it,
hormones.
right? Okay, next slide. Okay, next slide. Okay. Okay, so you're the thing, she's a 44-year lady with lump left breast. Dr. Pavindra is here, I think.
Hi, good evening, sir. Sorry for being late.
Good evening. No, that's fine. So we just finished this. We just Rajiv just go through the history fast.
Patient presented with a lump in her left breast for 3 months, sir. The patient was apparently normal 3 months back, after which she noticed the lump in her left breast incidentally while taking bath. It was insidious in onset and gradually increased in size to attain current size. The lump is associated with dull
So-
aching pain.
Just wait. I made a note of this. When have we discussed the history, sir? Not yet.
Yeah, I've just discussed it in brief. I've told him about all this thing about
Okay, so just finish the
coins and
presentation of.
softballs and all that kind of thing.
Yeah. So coin and softball is to be correlated with the size. You can say coin of a size of 1 centimeter by 1 centimeter to a softball size of 3 by 3 or something which she points with her finger.
Yes, sir.
Yeah, that is exactly what I wanted to say. Yeah, go on.
The lump is associated with dull aching pain for 2 days, which was following the corneal biopsy done prior. The pain was intermittent in nature with no radiation, no aggravating factors, and was relieved on taking medication. No history of nipple discharge or recent nipple retraction. No history of trauma to left breast. No history of any loss of weight or loss of appetite. No history of bony pain. No history of cough, chest pain, or breathlessness. No history of abdominal pain or distension. No history of headache, vomiting, or seizures. Past history, no history of any similar illness in the past, no known comorbidities, no history of any previous surgeries, no history of sterilization or radiation the chest wall, no history of intake of OCPs. Personal history, she consumes mixed diet, no history of alcohol consumption, not a smoker, normal bowel and bladder habits with normal sleep pattern. Menstrual history, she attained her menarche at the age of 15 years with regular cycles. Last menstrual period is 10/10/2025. She is married at 21 years of age, which is a non-consanguineous marriage, and she is nulliparous till date with no history of breastfeeding. Family history, no history of breast cancer in first or second degree relatives, no history of ovarian cancer, prostatic cancer, colorectal cancer, or pancreatic cancer in the family. Summary, a 44-year-old female presented a lump in her left breast for the past 3 months, history of pain or lump for two days with no relevant family history and no comorbidity. She is an nulliparous woman with no history of any breastfeeding.
So, what I would like to ask you is, Dr. Sahay, can I go in?
Please, all yours.
Yeah. So basically, what is is this a painful lump or a painless lump?
It was a painless lump, sir. Unless the corneal biopsy was performed, it was a painless lump.
No. So is the lump painless or painful? The simple question.
Painless lump, sir.
Painless. So be very clear in that the pain is only because of the needle intervention. The lump still continues to be painless.
Yes, sir.
All right. What is the importance of insisting on whether it is a painless or a painful lump?
It might have gone to skin changes like erythema in case.
No. Why are we saying that is it a painless or a painful lump? What is the significance of this pain association with lump?
Mastitis can present with painful. Mastitis is a painful condition.
What
No,
is painless?
Rajiv, your question.
Hello.
The question is that if it is a lump and which is painful and which is a painless lump, what is the basic difference between the two? What will come to your mind when you think there's a
Time-
painless lump in a 44 and a painful lump in a 44?
Painless lump, the most common DD is carcinoma, sir. And for a painful lump, it could be an abscess or mastitis.
What is age group for abscess then?
Sorry, sir.
What is age group for abscess? Or what are the
Reproductive age.
predisposing points considering it as a breast abscess?
Reproductive age group, it's usually occurs breastfeeding females.
And what is age group in your patient?
44, sir.
So what is your probable diagnosis by a painful lump at the age of 44 years?
Traumatic
What is
back
mastalgia? What is mastalgia?
pain or the breast, sir.
How it is classified?
Don't know, sir.
Arey, these are basic questions. What is cyclical mastalgia? What is non-cyclical mastalgia?
Cyclical mastalgia occurs during menstruation and non-cyclical mastalgia occurs throughout, sir.
So what are the causes of non-cyclical mastalgia? That's what sir is giving hint to you.
Mastitis.
Basically, what we are doing, what we are looking at is
Okay. What is ductal ectasia and mastitis? Periductal mastitis.
Around the duct, there will be inflammation, sir, and duct ectasia is dilatation of the lactiferous ducts.
So how do they present? So, Dr. Pavendra, yeah, you're asking something.
So I was just trying to, get this point about painful thing, which Dr. Gujar was trying to ask also, that what is the pathology which causes mastalgia?
Right.
You need to know about it, when you are presenting. See, the problem is this is not CA breast case. This is a lump breast case.
Yes.
And the viva is not supposed to be on lump breast, on CA breast. The viva is trying to understand your understanding about various issues with the patient,
Yes.
So it will go around many topics, and you are fixated only on carcinoma breast, unfortunately. So what do you understand by A and DI?
Aberration of normal breast involution, sir.
Aberration of normal
Breast involution.
A and
No, no.
DI.
Okay.
D.
It is not abnormal also. It's A and DI.
Aberration. It's aberration.
Aberration of normal breast
Development and involution.
breast development and involution, sir.
So what's the difference between abnormal and aberration? What's the
Abnormal
difference between the two? What is
abnormal is
abnormal?
pathological, sir. Aberrant is deviation from the normal, like
Right. Very good.
fibroadenosis.
Right. So there is a deviation from normal, right? Right. Now you answer in this case, why do you think it could be an abnormal deviation?
Could it be or could it not be? I mean, are you keeping it as a differential, or are you thinking that it is not an ANDI?
It could be an fibroadenosis, sir.
Why are you going now for fibroadenosis? You said it is a painless lump.
Painless lump.
Yeah, so
Sorry, sir.
so we are not trying to trap you, but we are trying to make sure that your understanding is clear. This is a painless lump. It is not a painful lump. Therefore, it has nothing to do with mastalgia and ANDI or any of those reasons at 44 years of age. Okay.
sir.
Now, if you come to the next points that you covered was that you asked for lumps elsewhere in the body.
Yes, sir.
Which parts of the body would you ask for a lump, a patient who has come with a lump in the breast? Which which areas did you talk about? Come to your next slide after this. No. Not the earlier one, the history slide. Before this. So, where is the history of lumps elsewhere in the body? Where is that history?
I have not mentioned it, sir.
How can that be possible? Patient, when comes with a lump in the breast, you need to ask, is there a lump in the same
Opposite
elsewhere in
breast.
the axilla, in the neck? Why do you ask about swellings in the opposite breast, in the opposite axilla? Isn't that history important?
Yes, sir.
So you can't miss that, okay? Make a point to ensure that you do not miss a swelling elsewhere in the body, okay?
Yes,
We
sir.
are talking about the drainage area of the breast. Patient may notice a swelling in the neck. She has not told you because she doesn't think it's of any relevance. But when you ask her, she says, yeah, yes, I can notice a swelling which has come up in the neck, which could be a lymph node, or in the axilla, which could be a lymph node, or another mass lesion,
Yes, sir.
Okay. And then you asked about history of nipple discharge. What type of nipple discharge would alert you to be of significance?
A serosanguinous discharge can occur in ductal papilloma or even in case of carcinoma breast. A
No,
greenish
serosanguinous is not what you are going to be worried about, my friend Rajiv, in this case. You are going to be worried about a blood-stained discharge,
blood stain.
right? What
Yes.
are the benign causes of blood-stained discharge? Other than malignancy, what is the commonest cause of a blood-stained discharge?
Ductal papilloma
Ductal papilloma. Good answer.
in
Is it a
case of
single duct usually, or is it multiple ducts?
multiple ducts, sir. Ductal ectasia is usually. Sorry,
Hello.
sir.
Hello,
Hello,
Hello.
doctor. Hello.
Hello, sir. Am I
What did
audible?
you? Hello.
Hello, sir.
Yes,
Am I
sir,
audible,
Dr.
sir?
Gujas.
Hello.
Yes,
We
sir.
can hear you, Dr.
What
Nishikant.
is,
We can hear you.
hello. Ah, what is color of discharge in case of duct papilloma and malignancy?
Bloody discharge, sir. Dark
Any
blood.
specification? Dark blood is seen in which condition? That's what sir was asking. Dark blood is seen in which condition and fresh blood is seen in?
Dark blood in case of papilloma.
Dark.
Don't know, sir.
How
Don't know, sir.
papilloma will present? It is from single duct
Bloodstain
or
discharge.
multiple duct? Huh?
Multiple ducts, sir.
Duct papilloma. What is treatment of duct papilloma? Do you know about duct papilloma?
Single duct, sir. Microdocectomy is done.
So fresh blood will get in case of the duct papilloma
Papilloma,
and
sir.
altered blood in case of malignancy.
So
Yes, sir.
basically, all examiners are trying to help you, Rajiv.
Yes, sir.
Right? So papilloma will be fresh blood, it will be single duct, and the hint for that is because you do a microdurcectomy of a single duct. Okay.
Yes, sir.
Now, why did you ask for nipple retraction?
Recent retraction of nipple occurs in cases of carcinoma, sir. Circumferential recent nipple retraction is a feature of carcinoma and
What does
slit
that signify?
periduct around the nipple areolar complex. The periductal fibrosis can cause circumferential nipple retraction, sir.
No, that is not the reason for nipple retraction.
Sir, what you told us circumferential retraction.
Yes, sir.
What does it mean, circumferential retraction?
The entire circumference of the nipple areolar complex will be retracted, sir.
What are types of retraction?
Slit-like retraction is seen in periductal mastitis.
Which is
Congenital
more important, slit-like, circumferential, or recent
recent
onset? Which is more important?
recent onset is more important, sir.
So what does this signify?
Recent onset means there is an ongoing pathology that has started recently.
So what
So
does it signify?
what is the retraction due to? Is the question.
Due to the fibrosis and involvement of the ducts by the carcinoma.
Which ducts? Which ducts will cause?
Lactiferous ducts.
No, it's not. It's not involvement of the lactiferous ducts which causes retraction. Where do the ligaments of Cooper finally insert around the nipple?
Don't know, sir.
What is the cause of puckering and dimpling if you see on inspection?
It's due to the involvement of ligament of Cooper, sir.
Right. So they come on and they fix onto the skin, right, at the various
Yes.
areas. Similar ligamental attachments around the nipple would do the same thing around the nipple, okay? Around the
Yes.
nipple areolar complex.
Yes,
Okay.
sir.
Now, next which you said was, can you go to the next slide? You asked for chest pain, cough, and breathlessness for which reason?
Metastasis from primary, sir.
Metastasis to what?
Metastasis to lung or pleural effusion can cause breathlessness, coughs, sir.
Breathlessness will be because of pleural effusion,
Pleural
correct?
effusion, cough
Yes.
and chest pain could be due to lung mets.
Yes, it could be because of the lung mets itself.
Even the
And
rib involvement can cause chest pain.
rib involvement can cause chest pain. That's correct. Why did you ask for jaundice?
Liver metastasis can lead to
How does liver metastasis cause jaundice, my dear friend? What's the size of the liver?
15 centimeters.
It's big, no?
Yes, sir.
So even if the liver is studded with metastasis, it will not cause jaundice. So please do not write this history. It's not needed.
Okay,
Unless
sir.
and until the metastasis is obstructing the extrahepatic biliary tree, it will not cause jaundice, right? Any one of us, we don't see people with jaundice. We treat M1 disease left, right, and center. I've yet in my life to see a jaundiced patient with CA breast. So don't take this history, okay?
Okay,
It
sir.
is not. It will just invite unnecessary discussion. So finally, when you say with case summary, what is your impression? Go to your last slide. So what is your impression from the case summary? Without any input from the examination, only on the basis of history, what is your differential diagnosis?
A female patient who is greater than 40 years of age with painless lump and nulliparous history probably could be a carcinoma of the breast, sir.
Okay, that's a reasonable one. I would invite anybody else if they have to say. We can move on for examination. If there is anything else remaining, we can cover it.
So what are the past histories you like to ask in a person with a breast lump?
Irradiation to chest wall, any other surgeries in the same breast or the opposite breast, or
So what kind of surgeries are you interested to know about?
previous lump or any wide local excision could have been done for a
So which are the
different
biopsy reports
lump.
you need to be aware of? You need to keep the patient on a follow-up.
Sorry, ma'am.
In other words, what are the risk factors pertaining to breast disease which carries a high risk? Okay, you're thinking the patient is having a fibroadenoma. You've done a biopsy, right? And the
Yes.
biopsy report doesn't come as a fibroadenoma, it comes as something else, right?
Yes, ma'am.
What is significance of menstrual history?
Early menarche and late menopause are risk factors for CA breast. Their increased estrogen exposure
Which
state
is
is a
more
risk.
important, early menopause, early menarche, or late? Which is important?
Early menarche, sir.
Hmm.
The difference between menarche and the
Or
first
period in
pregnancy.
between. This is important. Which one is important?
The period between the menarche and the first pregnancy, sir.
Hmm. Okay. What is the relation of this?
If
What is
the
significance?
period is more, the chance of risk of carcinoma is more, sir.
Any other history you want to ask?
Breastfeeding history, parity history,
What is the significance of breastfeeding history?
breastfeeding is a protective factor from carcinoma. Progesterone protects from.
What is significance of parity?
More the parity, less the risk for cancer, sir.
All these
Doctor,
questions in your mind, because these are very important, basic questions.
you need to be aware of atypical ductal hyperplasia with proliferation or without proliferation. Okay, these carries a very high risk of relative risk of these
Yes.
patients developing a breast cancer. So whenever you have any breast lump which has been operated, which has a biopsy report showing a proliferative disease, you need to under follow-up, right?
Yes, ma'am.
So that is the thing you need to ask in your previous history of surgery
Yes, ma'am.
pertaining to breast diseases. Fine?
Yes, ma'am.
Right. So, and regarding the patient, if the patient is nulliparous, then why you want to stress upon breastfeeding?
No, ma'am.
Uh,
It's nulliparous.
that is not required, I think, right?
Yes,
And she's
ma'am.
nulliparous, you need not stress the fact that she, again and again you are stressing both in the presentation and also in the summary, which is not
Sorry.
warranted. Okay,
Okay, ma'am.
right.
Okay, should
And
we go to
regarding
the
the
examination?
painful
Go ahead.
causes of breast, non-breast causes, what are the things you think of?
Fibroadenosis,
Non-breast causes, pain in that area. What will you suspect? Okay,
costochondritis,
right. Then
scurvy,
one is costochondritis. Then anything else which can cause a pain, which you need to be aware of.
scurvy causes scorbutic rosary.
I can't hear you, right?
Scurvy causes painful beats, ribs.
Not very clear, ma.
Scurvy, man. Vitamin C deficiency causes scorbutic rosary.
Oh, scurvy, right, fine, right. So, but usually the thing is, whenever the patient is going to have a little bit heavier breast, the lesion, when the breast is quite bigger, the patient will have a pull. So there will be a strain. The muscular strain would be there, right? So that will be a cause of a pain in the breast, but the actual pathology will not be within the breast lesion, right?
Yes,
So the
ma'am.
muscular strain can cause a pain, apart from your teeth syndrome, right? Fine.
Yes, ma'am.
Right. So, what do you mean by familial breast cancer and what do you mean by hereditary breast cancer?
Familial breast cancer is someone having breast cancer in a first or second degree relatives, ma'am. Whereas hereditary breast cancer is involvement of genes like BRCA1 or BRCA.
So, there might be a clusters of genes which might be running in that family, which might be having an implication towards a breast cancer. So, what will be the percentage of a hereditary breast cancer?
20%.
Is it more or less?
It's more than normal.
It's around 5 to 10%. 5 to
Yes.
10%. Okay. So, what are the genes you need to be aware
Yes.
of in a familial breast cancer, in a hereditary breast cancer?
BRCA1, BRCA2, P53 gene mutation can cause
Leaf-Romani.
leukemia.
Okay. Right.
Okay, can we go to the examination now?
Yes, sir. We can move on.
Yeah, Rajiv, examination.
General examination. On examination, patient is conscious oriented, well built and nourished. No pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. Blood pressure 120 by 70 millimeters per mercury. Pulse rate 68 beats per minute. Saturation 99% at room air. Local examination. After obtaining consent from the patient with adequate privacy and light exposure, with the female attendant by the side, the patient is made comfortable, then exposed up to weight, waist, and examined. On inspection, with patient in sitting posture with arms by the side of her body, position and symmetry of the left breast is comparable with that of the right breast. A fullness of about 7 cross 5 centimeters is visible along the lower outer and upper outer quadrant of left breast. No ulcers or skin over the breast is normal. No dilated veins, scars, or sinuses. No dimpling or tethering. No nipple retraction. Purely orange appearance noted over the lump. No nodules or no fungation. Nipple, bilateral nipple normal. Uh, left nipple is present at a higher level than right. No evidence of any accessory nipples. Left nipples appears a bit more prominent. No cracks, fissures, eczema. No active discharge seen. Areola colored dark brown. Left areola appears slightly larger than the right. No cracks, fissures, or eczema. Arms raised above the head. The lump becomes more prominent on raising her arms above her head. Left nipple is at a higher level than her right. No tethering of skin noted. Inframammary region normal. Hands against her hips. Right breast appears normal. Left breast purely orange becomes more prominent. On leaning forward, the lump falls forward freely along with the left breast. Right breast falls forward freely and equally. Axilla and supraclavicular fossa, right axilla appears normal. A fullness of about 2 cross 1 centimeter noted along the left axilla. Skin over the swelling is normal, well-defined margins. Supraclavicular fossa appears normal on both sides. Palpation.
Yeah, Rajiv, are you there?
Hello?
Yeah, Rajiv.
Rajiv,
Hello. I think
Rajiv said
still-
palpation and is here only, but we're not able to see him
all
here.
just a second. I think we've lost him. We'll just call him.
Yeah. Anagril, sir.
Yeah, I'm just calling him.
Yes, sir. He's moved out. Yeah, he's not here.
Yeah. Okay, for the benefit of the students, I'd just like to say something. Like he said, there's pain following a core biopsy. So the student must differentiate between local inflammation and pain because of the lump, of a painful lump. Right? So they have to answer. Right, I think he's come back. Yeah, Rajiv. Yeah, come. Just unmute yourself, Rajiv. Yeah, good.
Sorry, sir,
Right,
there was a
Raj.
power outage. Just a minute, sir.
Yeah, that's fine.
You
Just
know,
share your screen.
Am I audible now, sir?
Yes, yes.
yeah.
On palpation, lump was found to be fixed to overlying skin. Puree orange becomes more prominent. Lump is fixed to surrounding breast tissue. Lump is not fixed to underlying chest wall. Palpation of nipple, right nipple areolar complex normal. Left nipple, no nipple retraction on palpation. A mass palpable along the upper outer margin of left nipple areolar complex. Examination of axilla, right axilla, no palpable lymphadenopathy. Left axilla, a solitary node measuring about 2 cross 1 centimeter, globular in shape with well-defined margins, firm in consistency and not tender. No palpable supraclavicular lymphadenopathy. Systemic examination normal. Provisional diagnosis: a 44-year-old male, perimenopausal, probably a case of locally advanced carcinoma of left breast with TNM staging of T4B N1 M0, which corresponds to stage 3B. Am I audible,
Okay.
ma'am?
Yes, yes, you are audible. Let's go to your first slide of examination, please. Yeah, okay, that's fine. Next slide here. Next slide, yeah.
You
Okay.
said on inspection, you're able to notice a lump of 7 cross 5 centimeter on the left breast. But still, you're saying the symmetry of the breast is maintained. Do you think it is possible?
No, ma'am.
Huh?
No, ma'am.
Then why? And you have mentioned regarding this tethering. Tethering, is it an inspectory finding or a palpatory finding?
Dimpling is an inspectory finding, ma'am. Tethering is palpatory finding.
But you are stressing that it's tethering when inspection on repeatedly. Okay. So you need to be more careful regarding these words when you're going to put it inside, right?
Yes, ma'am.
Okay. How do you elicit a dimple if it's not visible?
We'll fix the lump And then along the direction
Dimpling
of
is a palpatory finding. Dimpling is a palpatory or
yes,
inspectory. How do you elicit dimpling? The question is.
dimpling will see a
On inspection. Madam is asking on inspection.
See, when you are not able to visualize a dimple, then can you make the dimple appear by doing a maneuver?
no.
No.
Hands pressed against the hips.
Okay.
Against, okay.
Any
You can
other?
raise the,
Okay, ma'am.
ask the patient to raise the arms
Yes, ma'am.
above and you can
And
try to look for
then
it.
yes,
Right? So what was the position of the nipple in your case, in your patient?
it was
When you ask the
uh,
patient to raise the arms above the head, what was the position of the nipple in your patient?
the left nipple was slightly above the right nipple, ma'am.
Okay. Was it drawn towards the mass or it is pushed away from the mass?
It's drawn more towards the mass, ma'am.
Okay. So those findings are relevant, which you need to tell. Because usually in a benign lump, what will happen? The nipple will get deflected. Whereas in a malignant lump, the nipple would be drawn towards the mass lesion, right?
Mass,
So that has
yes.
to
Why
be
is that,
looked for.
Rajiv? Sorry, ma'am. Why does that happen? That the nipple is drawn towards the mass on raising your hands?
It's involvement of the perianal. No idea,
Yeah,
sir.
tell me. Because
Involvement of
there's no
the
plastic,
surrounding breast tissue.
right? There's no plastic reaction, right? So
Yes,
that draws in the nipple towards the lump.
yes, sir.
Yeah, ma'am.
Okay. So this patient has
Okay.
got a lump which is involving both the upper and the lower outer quadrants.
Yes, ma'am.
And also under the nipple areolar complex, you are able to appreciate the lump. And there is a node which is present on the left side.
Yes, ma'am.
Okay. Right. So how do you elicit tethering?
Tethering will fix the lump and along the ligament of Cooper axis will scrape over the skin, ma'am. And if the axis is changed, there will be, if away from the axis of ligament of Cooper, there will be
You scrape the
fixed.
skin.
No, we'll just slide over the skin. Pull
Slide
the
you pull the skin.
we'll
Actually, when you
slide
try to
over.
hold the, you slide the skin over the lump.
Yes.
Is it? So usually what they tend to do is they tend to catch hold of the breast and they try to move the breast like a pendulum, right? So when you do that, what will happen? The lump will move along with the breast tissue. When it is being tethered with that of the ligaments of Cooper, there will be a tethering which will be able to appreciate. That is what we generally tend to do, not just by sliding the skin over it. Especially when you have a purity orange, you'll not be able to appreciate this tethering and other things. You say there was a purity orange which was present, right?
Yes.
So what is the reason for this purity orange?
Subdermal
I just like to
lymphatic.
Raji, I just like to point out one thing.
Yes,
Tethering,
sir.
dimpling, all this doesn't change your
The
staging,
staging.
Yes,
right?
sir.
That's important.
Yeah.
So whether it's tethering, dimpling, puckering, all that kind of thing, they're just descriptive items, but they
Yeah.
don't change your. Yeah, please go on.
Yes.
So which will
Due to
change your
involvement,
which will alter the staging regarding the
purity
skin
orange
changes?
will purity orange,
Mm.
satellite nodules and ulcerations will be considered
Right.
as skin involvement.
So what is the reason for this purity orange?
Subdermal lymphatic involvement and involution of hair follicles will lead to this appearance.
So subdermal lymphatics involvement causes what?
Involvement of the hair follicles in and the normal skin will swell and the hair follicles will
So
not
there will be an
will be
edema which will be present in the subcuticular region,
yes.
which gives that the dimpling causes the appearance of an orange peel.
Yep. Yes.
Okay.
Ma'am.
Is a purity orange always a hallmark sign of malignancy?
No, ma'am.
No.
But
So in what
purely
other
orange
condition?
is
In which other condition you can have a purely orange?
no idea.
No idea. So when you have an inflammatory condition and you have a mastitis, you can have a purely orange at times,
Yes,
right? It is not always a sign of malignancy, right?
yes,
Fine. So you said this patient has a skin involvement. How did you? You said there's some mobility test you did, on the skin. Something you were talking. Skin was free. That is what you are trying to tell me, or it is
no,
skin
ma'am.
was
Next time.
Skin was not
Rajiv, just go
pinchable,
to your
ma'am,
next slide,
over
please.
not
the lump.
pinchable. Okay, right. So
The skin
regarding the
pinchable thing, sorry, the skin pinchable thing is a bit dicey because the skin may be fixed to one point of the tumor, but may be free at the other side. So it's
yes, sir.
better to move the lump and see whether the skin moves along with it, which is known as the plato side.
Okay,
That's a better way to elicit whether the skin is involved or not. Yeah, ma'am,
yes,
please.
sir.
Yes, sir. Right. So coming on to the fixity to the deeper structures, what are the tests you did? You said it's not fixed to the chest wall. So what is the test you try to elicit?
We'll ask the patient to keep her hands over the hip and contract the pectoralis muscle and then move
Pectoralis
the
muscle,
blood.
does it form a part of a chest wall?
No, ma'am.
The question
It
was
doesn't.
how to identify whether the chest wall is involved or not.
Chest wall for serratus, in case of intercostal muscles or ribs, the mass will be completely immovable. In case of serratus anterior, we'll ask the patient to push against the shoulders or the wall and then move along and perpendicular to the fibers of serratus anterior, ma'am. And if it's restricted along the fibers of serratus anterior, it is involvement of chest wall.
No, Rajiv, when the
Rajiv,
one leaning
can I come in for
towards-
a moment, sir?
Yeah, please,
Yes, sir.
please. Pawan.
Yeah, so I don't think it's a good idea to talk about lump fixity within the breast, you know. Either it is
Yes,
fixed to the overlying skin or it is fixed to the underlying structures. You do not talk about it within lump is fixed or not fixed within the breast tissue. There is this description even in S. Das is incorrect.
And it makes no difference. If fixed to the breast, it doesn't change
It has no meaning
your
at all. It has no
your
clinical
staging.
relevance. Absolutely. I
Right,
agree with
right.
Dr. Saha. It has no clinical relevance whatsoever. You have
That
to
test is
actually say it's a single lump or a multiple lump, whether it is fixed to the overlying skin, and how you say that, as you were being asked just now. So I thought I'll just clarify that. Okay, have you understood that, Rajiv?
no, sir.
And
I'm not
also, I'd
able
just
to
like to tell
follow,
you,
sir.
what did you say,
You
Rajiv?
come to the point of your lump um, movement fixity, that slide. Yeah, lump is fixed to the surrounding breast tissue to be deleted. That
Okay,
line
sir.
needs to be deleted.
Okay, sir.
Yeah, that's what I'm trying to say. You talk
Okay.
about underlying, how do you check to the underlying muscle? I think madam was just asking you, Dr. Anandi.
Yes, sir.
Yeah, and how do you
Rajiv,
check for the fixity to the overlying skin? That you need to know. Okay.
Yes, sir.
Rajiv, when the patient bends forward and the lump doesn't fall forward, it means it's fixed either to the pec major or to the chest wall. Then you
Yes,
do the
sir.
pec major test, right?
Yes, yes, sir.
Right. And then if that's negative, you by inference, you infer that it's fixed to the chest wall.
Okay, sir.
Rajiv,
Yes, sir.
I will ask one basic question. How will you test fixity of the lump to the skin?
Sorry, sir. Fixity of lump to the
Skin. How will you test skin fixity?
in most cases skin will not be
What are the methods? How to test it?
pinchability.
Sorry.
Then
Basic
Inspection,
question. You are
palpation,
in a
some other
clinical lab.
testing, anything you can do.
On palpation, how will you test? How many methods are there? On palpation, how you test? How many methods are there given mentioned in clinical DAS? These are basic questions. First is there are three methods. One is the pinching the skin or the lump. Second and third method given in clinical DAS. These are basic, Raju.
Sir is trying to
Before
probe you.
presentation,
Plateau test will move the.
Okay. Gliding the skin over the lump.
Yes.
Hello. And you have to
Yes.
hold the lump and move in upward and downward direction. Okay. How will you test fixity
Yes,
of the lump to the muscle, pectoralis muscle?
We'll ask the patient to keep her hands against the hip and contract pectoralis major. And if along the muscle fibers and perpendicular, if the movement is restricted,
My question is how to test it. So position of the patient, position of the examiner.
We'll ask the patient to keep her hands on her hip and
Over the waist.
shoulders
And ask
forward.
him. Then first thing we have to palpate without pressing.
Sorry, sir.
First you have to test. Ask patient to keep her hand over the waist. First you have to check the mobility.
Yes.
And then ask patient to press over the waist. And first what we have to check? Lump or something else.
Rajiv, did you understand what Sir is trying to tell you?
Yes, sir. I'm understanding.
Okay, he's asking you to first hold the anterior axillary fold and see whether it is taut or it is loose. And then after you contract and relax it, you see whether it is getting taut. Then you need to do the test. That is what Sir is trying to convey. Is it so, sir?
Yes.
Okay.
Yes, sort of. Thank you. Continue.
Yes. And you have mentioned in your axilla as central quadrant. I think it's a typing error, right? We don't say quadrant within the axilla. Previous slide. Central group of lymph node, right?
Yes.
So there is only one lymph node which is present here, right?
Yes, ma'am.
Which is present and it's a globular shape, well defined, common consistency. And you need to mention whether it is a fixed node or it is a mobile node, which is not mentioned here. Does it alter?
Yes, ma'am. It alters. Added mobile. Mobile node, ma'am. Sorry, ma'am. I missed out.
So we'll go on with the right. So apart from that, what are the other things you need to examine beyond which you directly went on to the summary and your diagnosis? So what are the other things you need to examine in this patient? Your next slide. Next slide. Systemic examination, you have mentioned abdomen, no guarding, no rigidity. What is the thing you need to look into your abdomen examination?
Any mass for
What mass?
cancers.
Any mass?
Krukenberg's ovarian masses might be palpable per abdomen.
Ovarian mass. So when did she attain her menopause?
She did not attain her menopause.
She is not yet attained menopause. So you're thinking in terms of a Krukenberg tumor.
Yes.
Okay. Apart from Krukenberg's tumor, anything else you like to look into the abdomen?
Liver surface, if it's
Liver surface. First check out whether the liver is enlarged or not.
yes.
Okay. Then anything else you need to do in your other system examination? You're not talked about the perivaginal examination.
Yes.
So what are the things you look into your perivaginal examination? If it's a postmenopausal female?
Atrophic vagina.
Huh?
Atrophy of vagina can be seen.
Atrophy of vagina. In relevance to breast carcinoma, what are the things you need to look for while doing a pervaginal examination or a perrectal examination? Okay, fine. You need to check out whether the patient has got any blemish deposits.
Yes.
Okay,
Yes.
right? All those, and you have not examined the spine and the cranium. The first common site for a metastasis for a breast to happen is going to be where?
Lumbar vertebrae.
Lumbar vertebra. You didn't examine the spine and the cranium at all. You should look for any
Yes,
bony
yes.
tenderness. Where do you palpate for bony tenderness? In the
Along
bone.
the body of the spine, vertebra.
Very good. Not on the spinous process, right? Along the sides, you need to look whether there's going to be any tenderness, right? So all
Yes.
those things has to be completed when you do your systemic examination. Not only talking about the contralateral breast and axilla, right? All these
Okay.
areas are to be covered, right? So we'll
Yes,
move on
ma'am.
with your diagnosis.
Probably a case of locally advanced carcinoma of left breast, T4B N1 M0, corresponding to stage 3B.
Right. Sir, anybody wants to do anything else, sir, in the previous part of examination?
I think you can go to management, ma'am.
We can go for management, right? So how do you want to proceed in this patient now?
We'll first go for mammogram, ma'am. First routine blood investigations, then followed with assessment, of which clinical assessment is already done. We'll go for radiological assessment by mammogram,
Okay.
followed by uh, histopathological by core needle biopsy, ma'am, and FNEC from the lymph node.
Okay. Do you think a mammogram would be easy to do in this patient? What is the rationale behind doing a mammogram in this patient? The same
She's
side
more than
breast.
40 years old, ma'am.
Okay. More
Uh,
than 40 years. And she has got a
so
lump size of 7 by 6 centimeter. Do you think you can compress this mass within the paddle?
it will be difficult
And what is the rationale behind doing a mammogram in this side, same side breast?
to look for microcalcifications and speculated margins.
So you're trying to say that mammographically you want to prove that it's a case of CA breast. That is the reason why you are doing a mammogram. You're trying to look for what else? What is multicentricity and what is multifocality?
If more more than one tumor foci is present in the same locality, if it's present in more than one quadrant, it's multicentric.
Earlier it was sent as more than one quadrant, but now it has been redefined as the distance between the two should be
4
centimeter.
4 centimeters. Yes.
Say it is a multicentric disease.
Yes,
Okay.
ma'am.
So that you do mammogram mainly not only to diagnose or confirm your disease, it is mainly to look for any whether you have a multicentric or a multifocal tumor. And if you have a plan of doing a BCS on the same side, then you need to have a mammogram. Absolutely correct. Otherwise, the contralateral breast requires a mammogram, not for the primary lesion. Right?
Okay, ma'am.
So it's best to
Right.
picking up impalpable lumps,
Yes, sir.
right? You pick up impalpable lumps.
So if you have a very smaller lump, say around 4 cross 3 centimeter, in that case, we are going to do a mammogram. Additionally, impalpable lumps, as Sarah was telling, you'll be able to identify, right?
Yes,
So that
ma'am.
you can document about that, right? Right. So you have done a mammogram. What is the radiation dose in a mammogram?
Low amperage, high voltage, the radiation. Don't know, ma'am.
Don't know. Very good, right? Actually, last edition of Bailey gave the units as millisievert units around 0.1, but now the 28 says it is 1 mcgy, millicentigrade, right? That is the thing it has been given. Mgy, milligray, it has been given. Okay, so you can confirm it, which one you want to follow, and then you do it, right? Regarding the radiation dose for a mammogram. Now tell me, what are the mammographic findings in a breast to say it's malignant? What are things you need to look into?
Microcalcification, spiculated margins, taller than wider lesion.
Mm-hmm.
And axillary spiculated
So what are
margins
the
in
views which are taken in a mammogram?
mediolateral oblique and craniocaudal view.
What are the special views which are there in a mammogram?
Magnification view and spot view.
Compression view.
Spot compression view.
Okay, when you're not sure in a huge breast, when you're not able to localize it, in that case, you need to do a spot compression view and you try to identify it, right? Fine.
Yes.
So always all mammogram has to be combined with what?
Ultrasound of axilla.
Not ultrasound of axilla. Ultrasound of the breast
Breast
also
with
has to be done.
axilla. Yes.
So it is always a correlated one. Fine.
Yes, ma'am.
Right. So what are the when a mammogram will not be helpful?
In a young patient, mammogram will not be helpful, ma'am. Since
Okay.
more dense breast.
Right.
More dense breast.
Fine. Then
it cannot differentiate between solid and cystic lesions.
it can't differentiate between
Solid and cystic lesion.
solid and cystic. Okay. So that is the reason you don't do a mammogram.
No, ma'am.
Fine.
In case of pregnancy, for radiation exposure,
okay,
for avoiding radiation.
Good. Then
for recurrence cases, we prefer
when
MRI.
you have a scar, you will be having difficulty in identifying a mammogram. Okay, the
Yes.
lesion or it's going to be due to a scar disease, right? So in that
Yes.
case, what will be the best option?
MRI.
MR mammogram would be a better option, right?
Yes.
So now we'll go on with the core needle biopsy, you said, right? What is the size
Yes.
of the needle for your core?
14 to 16 gauge needle is used.
Okay. How many passes will you give?
6 passes has to be made, minimum
Right.
of 6 passes, preferably in the previous surgical incision site.
Previous surgical. Where is the previous surgical incision?
Planned surgical incision site, ma'am.
Within the planned surgical incision
Within the
site.
planned, yes.
Okay. You need to make your, fine. So you have taken a representative sample now.
Yes.
And you will be sending it to the pathologist. So what are the things you want from the pathologist?
To look for whether it's invasive,
while doing this core biopsy,
or not, if it's...
One second. While doing this core biopsy, will you do something else? We need to plan something else.
In the surgical...
Huh?
It should be within the future surgical...
That I accepted. Apart from that, anything else will you plan? See, you said it's a locally advanced carcinoma. What will be your management in your, what is the management you're having in your mind?
Neoadjuvant
as the upfront one option. Okay. If it's going to be a neoadjuvant chemotherapy, what is the thing you'll do after giving the chemotherapy?
RECIST criteria.
Okay, you'll do the RECIST criteria. So,
yes.
Okay. If you're thinking your tumor is going to achieve a complete response.
Yes.
Right? So what should have been done while doing your biopsy? What you should have done? You need to place a marker within the epicenter of the tumor. Right. So only when you place a marker, you'll know that where your tumor is going to be, because after chemo, your tumor might disappear. Okay.
Yes,
okay. Now having placed a marker and you have sent the specimen to the pathologist, what are the things you expect from the pathologist?
Whether it's a carcinoma or not, whether it's invasive or in situ, we can ask for immunohistochemistry like ERPR status and Ka67 status. and HER2 status.
And
Claudin can be seen.
anything else?
Claudin,
Okay. So apart from the immunohistochemistry, you should also ask about the any lymphovascular invasion which is going to be
Yes.
present within the tumor, so that you can know that you are dealing with a high grade tumor or not a well differentiated one.
yes, ma'am.
Okay, right. So now having done, for practical purpose, we'll take the tumor as to be a. Do you have a HP report here for this patient?
No, ma'am. It's
Not
still
right.
awaited, ma'am.
It's awaited, right? Okay, let it be a locally. I mean, let it be an infiltrating ductal carcinoma with a triple negative, right?
Yes.
So what is your plan now?
Neoadjuvant chemotherapy, and if it is responding, followed by surgery and then adjuvant chemo. Radiation.
Do you think triple negative cancers will respond to your neoadjuvant chemotherapy or not?
It has a poor response compared to luminal A and luminal B.
Triple negative cancers, they respond well usually to chemotherapy. Okay, those are the
Yes.
tumors, they usually tend to disappear, right?
Okay.
Fine. Okay, if it's going to be triple negative cancer, you have started on chemotherapy. How many cycles will you continue?
2 cycles we can give 2 cycles of AC, then wait for 3 weeks and take an MRI for RECIST criteria, and then look for the response. And then either we can go for surgery, or we can, in some cases, we can give 6 cycles on the trot and then go for surgery, and then we can.
So which are the tumors you will go and go for a complete, I mean, all the cycles will you give upfront? And which are the conditions where you will not give the entire cycle?
If they are partial responders or complete responders, we can give the all 6 cycles, ma'am. If not, we can go for surgery and then adjuvant chemotherapy can be used.
What is the rationale behind doing an upfront chemotherapy in a triple negative breast cancer? If
For
it's an operable tumor, why you want to go for a NAC, neoadjuvant chemotherapy? We have LABCs operable and inoperable, right? If it's
yes,
an
ma'am.
operable LABC in a huge breast with a lump, say about 5 or 6 centimeter, should you go for an upfront chemotherapy or you want to go for a surgery?
Upfront chemotherapy, ma'am.
Reason?
Downstaging of tumor can be done, ma'am, and the size can be decreased.
Is that the reason or some other reason is there?
The tumor burden can be decreased.
See, what happens is in a triple negative, we are not sure about what is the receptor status, right? If it's going to be a HER2/neu, you can target the therapy can be given. If it's a receptor positive, you give a tamoxifen. If it's going to be a premenopausal or postmenopausal, you go in for a GnRH analogs, right? But when you don't know what is the receptor status, we try to give your drug and we try to ascertain whether they are responding. So it is something like called as an in vivo assessment you're trying to do. Okay.
Yes,
So that is the reason you give a upfront chemotherapy in a triple negative breast cancer. Right.
Yes.
Right. So before going into for this chemotherapy and other things, right? Won't you do some other workup for your patient since it's a locally advanced breast cancer? We forgot about that.
Metastatic workup, staging workup has to be done, ma'am.
Okay.
CT chest, ultrasound abdomen and pelvis, skeletal survey or bone scan can be done, ma'am.
Okay.
Especially if ALP is positive, is more increased, ma'am.
So if the liver function test shows there is an ALP which is elevated, you go in for a bone scan. Is it so?
Scan.
So what type of an ALP you think is going to be elevated? It's a heat labile or a heat stable one?
Heat stable one, ma'am.
Heat stable. I thought it's a heat labile. Okay. You say still you want to do all this battery of investigations, or you can go with one shot, one investigation in an LABC?
PET scan can,
Uh,
yes, PET CT
Nowadays,
can be the,
almost every other institution goes for in an LABC, they go in for a whole body PET CT only, right?
yes, ma'am.
All this battery of CT chest and other things are not done nowadays. Okay,
Okay, ma'am.
right. So now your tumor, what is RECIST criteria?
Uh, it's when complete responders can
Expansion of
respond,
RECIST.
response evaluation criteria in solid tumors.
Very good. Okay. So what will be the pattern
Complete
of see, in what kind of a pattern of response the treatment would be better?
in complete responders, treatment would be better.
Okay. Usually you don't expect a complete responders, right? There will be a partial
Yes,
responding
ma'am.
kind of a
And
thing will be there,
partial
right?
responding.
So in a
Yes,
partial responder, what is the
complete and
pattern of
partial
response?
respond.
What will be the pattern of response?
Concentric
In
or it's
very good. It could be either a concentric
concentric,
response or an eccentric
concentric or
response.
eccentric response.
Right. So this
Concentric is
eccentric
more
response, mm, it is more
better in prognosis. No?
okay. So the thing is, whenever you have a concentric response, you can go in for a breast conservative surgery if at all, if they are able to offer it. Okay.
Yes, ma'am.
But in an eccentric response is something like a cheese kind of a Swiss cheese kind of an appearance. There will be a response patchy which will be in one area and other areas. In that case, you'll not be able to offer a breast conservative therapy. In that case, you need to go only for a surgery which will be a modified
Ma'am.
radical mastectomy. Right. Okay. Now your patient has responded and that there is a tumor which has now regressed to about 4 by 3 centimeter after your second cycle, right? And you have done a
Yes.
evaluation, is found out that there is a tumor has responded. Now, what is your plan?
If the tumor is responding, we can continue with 6 cycles of AC and then continue with surgery.
Okay. What are
Modified
the
radical mastectomy and
before?
then
But I am stopping the patient. I am not continuing the chemotherapy. I am planning in for surgery. So, what made me stop? So, what are the things which will defer my plan to continue the ongoing chemotherapy?
side effects of the drug, patient not able to
So, what should be the performance status of the patient?
and
It should
the
be
general
above
condition of the patient.
general condition. Okay.
Uh,
The performance status should be over and above 60, right?
okay.
To continue your chemotherapy. If it's going to drop down, then that's no point in continuing your chemotherapy, right?
Yes, ma'am.
So in that the case you can go for the next line of management, right?
Yes, ma'am.
Okay. So what is the surgery you're planning for?
Modified radical mastectomy.
Right. So what are the types of incisions which are available for doing a modified radical mastectomy?
Steward's incision, modified Steward's incision, or incision, elliptical incision.
So what is the amount of clearance you want to give?
1 centimeter, ma'am.
Right. Okay.
1 centimeter from all the tumor margins.
So what are the structures which are removed while doing a modified radical mastectomy?
Breast along with the nippile-areolar complex, spectralis fascia, level 1 and level 2 axillary lymph nodes, along with skin.
So it is better always start with breast with the overlying skin along with the
Skin,
nippile area complex
later.
and the tumor along with the pectoral fascia, right? So what are the
Yes.
structures you need to preserve?
Pectoralis major and minor.
What are the nerves you preserve?
And thoracodorsal nerve and nerve 2. serratus anterior, ma'am.
Any other nerve?
Intercostobrachial nerve can be sacral.
Okay. Any other nerve which you need to take care of? Which other what is the nerve which comes at the superior most level of your muscle when you go into the axilla?
Axillary nerve.
Axillary nerve.
No, ma'am.
Medial pectoral nerve. Right. You need to
Yes.
look for it and you need to preserve it. Why?
Pectoral
That
is
will be
major
it will be
and
supplying your
minor will
muscle.
be.
Right. If you're not going to preserve those nerves, then what will happen? Your muscle, there's no point in doing your modified radical mastectomy. That
Modified
muscle will go.
radical.
Okay. Fine. Now your specimen goes to the. I have done an axillary dissection also, right? So after doing an axillary dissection, what will you do?
Sorry, ma'am. After
Doing your axillary dissection, what will you do? You've
we'll
done a
clear
mastectomy with an
level
axillary.
clear level 1 and level 2 nodes, ma'am.
Why not level 3?
Level 3 doesn't give much of an advantage, ma'am. For level 3 pectoralis minor, retraction alone is difficult. We may have to divide pectoralis minor, and it's not usually needed.
When you're dealing with an early breast carcinoma, in those cases, you can leave behind your level 3. When you're dealing with LABC, usually we go for the level 3 nodes also, right? As such, your
Okay.
Bailey book says when you want to do a modified radical neck dissection, it includes not neck dissection, modified radical mastectomy. You need to remove level 1, 2, 3 lymph nodes, right?
Okay.
All the 3 groups are removed, right? So, what is
Okay,
level
ma'am.
2 lymph nodes?
Behind the pectoralis minor, ma'am. Interpectoral nerve.
Only behind. What group does the rota's
interpectoral
lymph node
rotus
also belong
nodes.
to? That also comes under
Level 2.
level 2 group of lymph nodes. Right.
Yes.
Anybody wants to take over, sir?
What is sentinel lymph node, Raju?
Uh.
What is sentinel node?
The lymph node that first, the node that first drains the tumor is known as the sentinel lymph node. Sentinel lymph. Am I audible, ma'am?
Yes, very
Hello,
much.
your voice is breaking for me. Okay, I think some net issue. What is sentinel node and what are the indication of sentinel lymph node biopsy?
The first node that drains the first node that drains tumor is known as the sentinel lymph node. And
okay,
for T1 and T2 tumors where there is no palpable axillary lymph node, sentinel lymph node biopsy can be done.
how do you localize sentinel node?
We'll inject the patient with methylene blue and then massage the area for 3 to 5 minutes, and then using a gamma probe, we'll look into the axilla and find out the sentinel lymph.
Hello.
Hello?
If sentinel lymph node is positive, then how do you treat the axilla?
We'll go for axillary dissection, sir. Level 1 and level 2 nodes have to be removed.
Hello.
Hello?
Hmm.
Am I audible, sir?
Yeah, but there is. Your voice is not clear for me, I think.
If it comes out to be positive, we'll go for Am I audible?
Your voice is breaking. Is it raining at Madurai?
Yes, ma'am.
That is the reason, I think.
Yes. Is it breaking out too, ma'am? Hello, am I audible, ma'am?
Hello? Can you hear me?
Hello? Yes, ma'am, I can hear you, ma'am.
Yeah, I can hear you now. Right. I think Nisar sir was asking you some questions.
Biopsy, if it comes out to be positive, we'll go for level 1 and level 2 axillary dissection.
Okay. Nobody's there. Okay, tell me what are the prognostic?
complications of mastectomy?
Sorry, sir.
What are the complications? What are the complications of mastectomy?
Seroma formation,
Hmm.
axillary lymphadenosis, lymphedema of upper limb,
Hmm.
flap necrosis, wound dehiscence, and then in rare cases, after many years, lymphangiosarcoma can occur in cases of chronic lymphedema, extremely rare cases.
Okay, continue.
So now tell me what are the contraindications for an LABC in a person, I mean BCS in an LABC.
First, if patient itself is not willing for
Okay.
LABC or previous irradiation to chest wall, if patient is
Okay.
pregnant, if patient could not afford radiotherapy, they should be compliable. They should be They should have complaints to other to radiotherapy. Then these are absolute contraindications and relative contraindications in case of multifocal disease. Yes.
Again, your voice is breaking. Relative contraindications, sir.
Multicentric and multifocal
Okay.
diseases.
Multicentric and multifocal. Okay, good. Then okay. Regarding the sequencing of treatment, how do you go about?
Yes.
Which will give offer first?
Sequencing in the sense.
Sequencing
First,
is will you
breast
give
conservation surgery
chemotherapy?
followed by radiotherapy.
Okay. Regarding hormonal therapy and chemotherapy, which one will you give first and which one will you give later? Or you will combine both the things together?
Chemo will give first, ma'am, and then hormonal will continue till 10 years.
Hormone 10 years. What is the dosage?
Tamoxifen for 20 mg for 10 years, ma'am.
10 years. What are the side effects of tamoxifen?
Flushing, thrombosis, DVT, increased risk of endometrial carcinomas.
Okay. What is the advantage of giving a tamoxifen?
In here, it's selective estrogen receptor modulator, ma'am.
Is it bone friendly?
Yes. It is bone friendly, ma'am.
So that is the advantage of using a tamoxifen. Compared with, okay, if it's a postmenopausal female, what is the hormonal therapy you'll prefer?
Aromatase inhibitors, anastrozole and letrozole.
Right. Okay, how do you prevent seroma formation in a breast when you do an MRM?
Suction drain can be kept.
Okay.
Compression,
Otherwise,
breast
you don't keep a
exercises.
suction drainage generally?
No, ma'am, we'll keep for every case. We'll advise for breast upper limb physiotherapy and exercises.
Okay. So meticulous hemostasis is the first keystone, right?
Okay.
Right, try to achieve that and
yes.
obliterate all the dead spaces. preferably, right?
Yes.
So
Yes,
how do you
ma'am.
obliterate any technique you'll adapt to obliterate the dead space?
Quilting can be done to obliterate
Quilting.
axillary. Yes.
Yeah, you try to do a quilting sutures, it will try to narrow down the space so the seroma accumulation can be reduced in these kind of things,
Yes.
right? Fine.
Yes, ma'am.
So post-operatively, now the specimen has gone to the pathologist. What will the pathologist do?
They look for margins and
What is the ink margin?
microscopic margin, ma'am. Ink on
Microscopic
tumor
margin.
ink on tumor means there is
Uh,
microscopically the margin is not positive. The margin
okay,
is positive. It is
right.
not cleared of malignancy.
So what should be the clearance to say that the patient has achieved a clearance?
Minimum of 1 mm should be there, ma'am.
There should not be any ink on the tumor.
Yes, ma'am.
No ink on the margin, actually, not on the tumor. And it
Yes,
will
ma'am.
be okay. That is the thing you need to look into when you ask from the pathologist what is the report, right? And what are the
Yes.
other things you like to ask from the pathologist?
We can look for vascular invasion, lymph nodal status, IHC can be done.
Right? Then, so how do you assess, how do you explain the prognosis to the patient?
Histological grading can be done.
Okay, then,
Prognosis, if it's positive, margins positive.
okay.
Hello, ma'am.
So regarding histological types, which are the types which has a favorable prognosis?
Tubular type, medullary type are more favorable. Adenosystic has a good prognosis.
Okay.
Tubular, medullary, adenosystic all have good prognosis,
Tubular,
ma'am.
cribriform, medullary, adenoid cystic, they all have a better prognosis
Better
accepted.
prognosis.
So you need to know about all these things from your pathologist to talk with your patient to say that you are
Yes.
doing well or you're doing good. Okay.
Yes,
Right?
ma'am.
Like that, what are the other things you need from a pathologist? Not only the histological type, what are the other things you need?
Immunohistochemistry can be
Okay, done. Then
histological grading, nuclear mitotic
okay, done.
index, and
Very good. Right. Then you need to start from the age of the patient, the size of the tumor, the grade of the
yes,
disease. Then you need to talk about
lymph nodal involvement,
lymph nodes,
number of
right?
lymph nodes involved.
Number of lymph nodes. Very good. So so whenever you take a specimen out, you need to always dissect your specimen and see what is the number of lymph nodes you have taken out. So there should
Yes,
be at least a minimum of
10 lymph nodes in case of
10
breast
nodes you
cancer.
have to take it out, right? If they are not going
Yes,
to do
ma'am.
an adequate dissection of your axilla, then you need to address the axilla again,
Yes, ma'am.
right? Because the patient will end up with your recurrence. So always two arms should not be employed in the particular area. Like if doing a surgery and doing a radiotherapy to the axilla, this will cause more amount of lymphedema and other damages. So you do a perfect surgery. Okay.
Yes,
Namlala,
ma'am.
it's not say that, okay, this is not coming out. This can be taken care by radiotherapy people. Like that, you are not supposed to do. Right? Do a perfect
Okay, ma'am.
dissection and try to clear out the entire area. Right?
Yes,
So,
ma'am.
what is the level of your axillary dissection? Superiorly, it is going to be your axillary
Okay.
vein.
At superiorly, anterior-inferior border of axillary vein.
Uh,
Inferiorly, it's the angular vein.
very good.
Medially, Halstead's ligament, and then
Right.
laterally, it's thoracodorsal pedicle.
Okay. So medially, if it's a Halstead's ligament, then that means you're going and removing level 3 nodes. Are you sure? Right.
Yes.
Ah. In that case only you'll be able to remove the entire lesion, right?
Yes,
Okay.
ma'am.
Okay, when will you remove the drainage tube in a person?
There is
Mm.
less than 30 ml of uh, discharge for consecutive 2 or 3 days, ma'am.
Okay, less than 20 ml on the consecutive 2 or 3 days, you'll tend to remove the drain. But if your drain is
Yes.
coming almost on the 10th day, also more than 50 ml or 100 ml, right? In that case, what will you
Yes.
do?
We can wait till 14 days.
Okay. And after 14 days, even with the 50 or 100, you'll remove it. You do an ultrasound and see what is the collection. If the collection is persistently high, you try to reposition the drainage tube in an apt position so that you'll be able to facilitate the drainage in a better way.
Hello?
Okay. Reposition the drainage tube to facilitate a better drainage.
Okay, ma'am.
Okay,
Yes, ma'am.
fine. So what are the types of breast conservative surgery you know about?
Don't know, ma'am.
Do know. Heard about lumpectomy,
Yes, ma'am. Lumpectomy,
Ah,
quadrantectomy.
then you said that. See,
Ah,
don't give up immediately, ma. You need to think over an answer, right?
okay.
Ah,
Lumpectomy, quadrantectomy followed by axillary resection and required regimen, and then white.
So the first thing you should talk is about not lumpectomy alone. You should talk about what is called as a wide local
Wide
excision.
local excision.
Okay, with a clearance of 1 centimeter all around the tumor, right?
Yes, yes, ma'am.
Okay. So while doing a lumpectomy, what are the procedures you need to follow? For imagine there is going to be a lump which is going to be around 2 centimeter, right? What are the things you need to plan?
The incision should be adequate, ma'am. Nipple areolar complex should be saved.
Okay.
The skin should be, if there is more than 1 centimeter between the skin and the tumor, the skin can be saved. And
Okay.
pectoralis fascia also need not be removed if there is adequate margin available.
Right. And don't try to undermine the skin flaps. You try to preserve the skin flaps. Go in the
Preserve the
full
skin
thickness
flap.
and then take it out. Okay, now how do
Yes.
you orient the specimen in a breast conservative surgery to the pathologist? When there's no overlying skin, how do you orient the specimen to the pathologist?
Will superior short will tie 2 sutures, ma'am. For
Very good.
superior end will tie short suture, and for the lateral end will tie a long suture.
Very good. Some people even put in a double deep.
Yes, ma'am.
Okay, that they also do, so that the end thing will be oriented towards the pathologist will know which is the area they have to look into. Okay,
Yes, ma'am.
right. So coming back to having done a mastectomy, patient is going to be a young age, say about 40 years. What are the things you like to take care of? Having completed the surgery, having completed the chemotherapy, anything else you like to offer to your patient?
Follow-up should be made, ma'am, for at
Right.
least
How do you
for the
follow up the
first
patient?
the first 2 years. The maximum amount of recurrence occurs in the first 2 years, so there should be vigorous follow-up in the first 2 years. At least annual mammogram must be taken.
Okay.
Free medical examinations must be done, and patient should be taught to examine herself.
Right. Anything else you like to do regarding follow-up? Follow-up is only a clinical examination and annual mammogram.
No, no idea.
No idea. So our aim is to look for any primary which is going to develop in the contralateral side, right? So do an annual mammogram, which is mandatory, and you have to do an ultrasound of your abdomen to look for any other metastasis which is starting to develop there, which has to be done, right? But now people, they
Okay.
also go in for a annual PET CT also they do as a part of the follow-up, right? To see whether the patient has got any other recurrence which is going to be noted, right? So coming on to reconstruction, when will you offer reconstruction to your patient?
More than 20% of the volume of breast is removed, we can always reconstruct.
Okay. So in a breast conservative surgery, you go in for a removal of the part of the breast. When there's going to be 20%, you go for reconstruction. So what are the
Yes.
methods of closure you're trying to achieve? What is volume displacement and what is volume replacement?
Volume replacement.
Mm.
Volume displacement will just displace the lateral the breast tissue to the tumor site,
So,
ma'am, and replacement will add an external.
so when will you go for a volume displacement? When you have a huge breast, you can do a volume displacement technique and try to close the area, and you can do a reduction mammoplasty on the contralateral side so that you can match the both the sides.
Yes.
Okay.
Yes.
But if you are having an emptiness, when you're not able to achieve the volume displacement, in that case, you go in for a volume replacement, wherein which will be filled up with the flaps from the where a tram flap, or it will be a
Flap, ma'am, transverse
or a
rectus abdominis flap, or
LD flap.
latissimus dorsi flap.
Mm. You can bring those flaps and you can try to bring about the thing. So when will you offer a reconstruction? It will be a simultaneous procedure or a delayed procedure. Which one will you prefer?
Simultaneous, ma'am.
What is the advantage of a simultaneous procedure? What is the disadvantage of a simultaneous procedure?
Can be done in a single sitting.
Okay. The disadvantages include?
Long operating time.
Okay.
If
Then?
there is any residual margin
when there's going to
positive,
be
the
a positive
radiation
margin,
may affect the flap.
So
the further treatment might affect the flap.
Yeah, if the patient needs the radiotherapy or anything, what will happen? The flap will not maintain its own integrity.
Yes.
What will happen? It will shrink, it will contract. So the cosmosis will not be of adequate nature, right? So
Yes,
people
ma'am.
prefer to go for a delayed reconstruction many times, right? To avoid these issues.
Yes.
Right. So,
Raju?
Yes, sir.
Yes, sir.
One question. What are the newer biological agents?
HER2 receptor antagonists are trastuzumab or herceptin, and for brain mets lapatinib.
Okay.
HER2 receptor antagonists are trastuzumab, monoclonal antibody acting against the HER2 receptors. And then lapatinib can be used for brain metastasis.
Okay.
Bevacizumab can be used.
How do you treat the locally advanced breast carcinoma, and how do you treat the metastatic breast carcinoma?
For locally advanced, we'll start with neoadjuvant chemotherapy and will downstage the disease followed by surgery, and then adjuvant chemo if needed can be given. For metastatic, surgery is only offered for symptomatic relief, or for conjugating ulceration, only toilet mastectomy can be done. If there are no indications for surgery.
For metastatic carcinoma or for locally advanced carcinoma? What is the meaning of toilet mastectomy?
Just removing the breast tissue alone, sir, along with the fungating ulcer.
Okay. And metastatic carcinoma, how will you manage?
If it is causing spinal compression, in some cases, laminectomy can be done. Brain meds, lapatinib is given, and for radiotherapy can be given if severe pain is there due to skeletal metastasis.
Okay. What are different chemotherapeutic drugs?
Adriamycin, cyclophosphamide, docetaxel,
How many cycles?
AC 4 cycles followed by AT 4 cycles, recent 6 to 8 cycles recent.
Okay. What are the complications of these drugs?
Adriamycin is cardiotoxic. Cyclophosphamide causes hemorrhagic cystitis. Taxanes causes immunosuppression. And the major problem is immunosuppression and white blood cell decrease. In some cases, filgrastim can be used, granulocyte monocyte factor, for improving white blood cell count.
What is the role of radiotherapy in early breast cancer?
If patient wants to go for breast conservative surgery, radiotherapy is given in case of early breast cancer. And node positive, we can for node positive cases in early breast cancer, radiotherapy is given.
Okay. What is the indication for adjuvant systemic therapy?
HER2 positive cancers, triple negative cancers, and then margins positive, lymph node positive in case, and then locally advanced breast cancer. For all these cases, adjuvant chemotherapy is given.
What is nature of action of tamoxifen?
SERM is a selective estrogen receptor modulator. It it acts as anti-estrogenic in bone receptors and then pro-estrogenic in all other tissues.
What is familial breast carcinoma?
Sorry, sir, I couldn't hear you.
What is familial breast carcinoma?
Familial breast
Familial breast cancer.
Familial is genetic, hereditary familial breast cancer where the first degree or second degree relatives have genes like BRCA1, BRCA2 where it is passed down in generations.
Hello, madam.
Okay, sir. So regarding if the patient has got a hereditary breast cancer, right?
Yes,
How
ma'am.
do you counsel the family members?
Annual mammogram after the age of 20.
After the age of 20, mammogram.
40, ma'am, 40, sorry.
Uh,
After the age of 40, annual mammogram is advised.
Okay.
Regular examination.
So that is a routine thing we generally do for everybody, no? What is the screening we do in the mammogram? When will you start the mammogram?
25 years.
25 years screening. Mammo.
M.
Huh?
No, ma'am.
Then when? So usually we will start at the age of 40. Generally we do one, but we don't do it annually. Annual mammogram happens after the age of 50 years only. Right?
Okay.
So this will be a baseline mammogram which we have taken. But what you do is whenever you have a family history or a hereditary risk of breast cancer, then for example, if that mother had developed a breast cancer at the age of 50 means the screening has to start little bit around at least 5 to 10 years ahead.
Yes, ma'am.
Okay. So do it at a earlier age so that you can try to pick up the lesions in a what to say earlier stage because the doubling time is always there, right?
Yes, ma'am.
So will you offer a prophylactic mastectomy?
Yes, ma'am.
Yes, sir. Very good. Right. When and for
After
whom?
family is completed, if mother or sister is
Uh,
if she's DRCA1 positive with the first blood relative with positive of breast cancer and family
all
completed, we can
BRCA
offer.
will all BRCA people will surely develop malignancy?
No, ma'am.
And then why you want to offer a prophylactic mastectomy?
Increased risk.
Increased risk of genetic mutation, right?
Yes, ma'am.
Okay, so if there is going to be more than 2 first degree relatives, if they are going to be present in that family, then you can
Yes.
offer them a prophylactic mastectomy. If they are willing, they can go in for a
Go
prophylactic,
breast.
right?
Yes.
So
Yes,
it's
ma'am.
something like a preventive surgical thing you are trying to do, right? Will you offer?
Yes.
So you want to do a bilateral or a
Bilateral,
sorry,
ma'am.
prophylactic mastectomy? For a
Yes,
person who
ma'am.
has already undergone a mastectomy on one side, will you offer a contralateral prophylactic mastectomy?
Yes, ma'am.
Okay, how do you assess the recurrence scoring?
MRI.
MRI. Then anything else for recurrence scoring assessment? Any other genetic test or something which is there available?
Oncotype DX.
Ah,
Oncotype DX and Mama print.
mama print. And then endopredict.
Yes.
Likewise, lot of tests has been available in the market which can be used, right? So what
Yes,
are
ma'am.
the risk assessment models which are available and which can be used in these patients?
No idea, ma'am.
You heard about Gale model,
No, ma'am.
Claus model, Cubics model, all those things models are there, right? You just go through that
Okay.
and you can try to identify and see whether what is the best which can be offered for your patient, right? Whether your patient
Yes.
requires a genetic counseling or the patient requires a screening like that, you can advise depending upon what is the class and what is the stage of your patient, right?
Yes.
By doing
Yes,
this,
ma'am.
right? Like what was the age at menarche, what was the age at first childbirth, all these inputs has to be taken into it, and you need to calculate the absolute risk whether this patient develops this malignant. Is there a chance or a lifetime risk which can be there? Like that, you can try to estimate, and you can
Yes.
offer this solution to your patient, right? So this called as
Yes,
a
ma'am.
breast cancer risk assessment tool. Lot of
Yes.
apps are available nowadays in your online. Okay, but there's
Yes,
all
ma'am.
those are paid apps only, in which you can feed these details, and then you can try to assess and try to see whether there's any high risk propensity for your that particular family female to develop a breast malignancy. Right,
Yes, ma'am.
right, fine. Rajiv sir,
Very detailed discussion. Very nice.
Yes, sir.
Very well done.
Yes, sir.
Anyone else would?
It's already
Right.
time up.
Yeah, very well done, Rajiv. Do you have any questions for anyone? Any queries? Professor Nishikant, would you like to
No, sir.
assess
Madam
his?
already covered all topic, all exam related questions.
Mhm.
Very nice discussion.
Yes, sir.
Very detailed. So thank you
Thank you.
so much. Thank you,
Thank you,
ma'am.
sir.
Thank you, sir.
Thank
We'll
you,
call
sir.
it a day. Right.
Thank
Good
you.
night,
Thank you,
everyone.
ma'am. Thank you, sir.
Raju, nice
Rajiv,
presentation. This
good.
video is available on YouTube.
Thank you, sir.
Please go through it. Madam covered all
Yes, sir. Sure,
exam
sir.
related important topics.
Yes, sir.
Okay. All the best.
Thank you, sir. Thank you, ma'am.
Good. Well done, Rajiv. Who's your chief?
Saravanan, sir. K. Saravanan.
Okay. Okay. Right. Well done. Well prepared.
Th-